Welcome to This Explainer. Today, we're diving straight into a hidden, often devastating occupational hazard, the rigorous scholarly landscape of moral suffering in modern healthcare. Now, we all know the contemporary medical environment is incredibly complex, right? It's defined by profound clinical and technological demands. But here's the thing. While the technical side of patient care is rigorously drilled into medical students, the ethical and psychological toll of navigating massive systemic pressures, that's emerged as a critical reality that we really need to talk about. We're going to unpack the science and the psychology behind what actually happens when clinicians are systematically prevented from acting on their core ethical beliefs. Here's our roadmap for today. We'll start with the spectrum of moral suffering, then look at quantifying the psychological toll, interventions for moral distress, and therapies for moral injury. Then we'll examine pediatric palliative care dynamics, and finally, building resilient ethical climates. This provocative question sits right at the heart of our explainer today. It sets up the absolute high-stakes reality that healthcare workers face on a daily basis. Imagine for a second knowing the exact, ethically appropriate medical action to take for your patient. You know what they need, but you're completely prevented from doing it because of chronic understaffing, strict institutional policies, or resource triage. The intense dissonance between your fundamental oath to do no harm and the rigid, systemic constraints of modern medicine creates an inescapable state of moral tension. Okay, Section 1. Let's look at the spectrum of moral suffering, specifically distress versus injury. It's absolutely crucial that we clinically separate these two concepts. We need to distinguish between the catalysts and psychological impacts of distress versus a deep existential injury. Moral distress, a concept first introduced way back in the 1980s, is essentially driven by institutional constraints that make an individual feel totally powerless. That leads straight to acute frustration and clinical burnout. Moral injury, on the other hand, actually has its conceptual roots in military psychiatry. It happens during high-stakes events that involve severe, perceived transgressions or profound institutional betrayals. So we aren't just talking about a frustrating day at work here. We're talking about deep, toxic shame, self-condemning guilt, and literally PTSD-like symptomology that can cause a complete collapse of a clinician's professional identity. So what happens when this distress goes unresolved? It doesn't just vanish at the end of a shift. No way. It compounds. Scholars actually refer to this as the crescendo effect. Every single time a clinician faces unresolved moral distress, it leaves behind this heavy residual psychological burden known as moral residue. Think of it like a buildup over weeks, months, and years. It effectively alters the clinician's moral baseline, meaning that any subsequent ethical conflicts they face become even more damaging, driving them further and further towards psychological depletion. Moving into Section 2, quantifying the psychological toll, where we look at how we measure both suffering and resilience. You simply can't fix a problem if you can't measure it accurately. That's where these validated psychometric instruments come into play. They're vital tools allowing the medical community to track the severity of distress across broad clinical populations. For example, the Measure of Moral Distress for Healthcare Professionals, or MMDHP, captures the highly specific experiences of interprofessional teams. It helps identify key structural drivers, like poor team communication. Meanwhile, the Moral Distress Scale Revised tracks the actual frequency and intensity of these distressing events. And then there's the Moral Injury Event Scale, which was directly adapted from military populations to measure exposure to perceived betrayals by leadership or the institution itself. Now let's look at the Rushton Moral Resilience Scale. This one is really fascinating because instead of just measuring the damage, it measures the proactive capacity a person has to navigate moral adversity. It identifies 4 core factors that strongly correlate with lower burnout and lower turnover in tensions. Take a look at personal integrity, which is the alignment of your clinical actions with your core values. That actually acts as a direct shield against the deep shame of moral injury. Then there's moral efficacy, which is basically believing in your own capability to affect change. That directly counteracts the learned helplessness that drives moral distress. Likewise, relational integrity helps mitigate the distress that stems from interprofessional conflict. The data shows that high scores across these specific subscales consistently correlate with significantly lower rates of depression and secondary traumatic stress. All right, Section 3, Interventions for Moral Distress. How do we go about empowering the clinician? One of the most comprehensive interventions you'll find in the literature is MREPRA, the Mindful Ethical Practice and Resilience Academy. The core premise here is actually biological. Ethical deliberation is neurologically impaired when a clinician is in a state of sympathetic nervous system hyperarousal. You know, that classic fight or flight mode. You just can't think clearly.
By combining values clarification with high-fidelity simulations, both novice and highly experienced nurses learn targeted mindfulness practices to essentially down-regulate their somatic responses. They learn how to regulate their breathing and intentionally create the cognitive space required to actually make moral discernment during an acute clinical crisis.
Unlike your typical clinical ethics consults, which are usually heavily focused on patient rights or bioethical principles, the health system-wide moral distress consultation service operates differently. It uses these structured steps to heal the interprofessional team itself. Through what they call facilitated ethics conversations, a trained facilitator guides the medical team to focus on the underlying systemic dysfunctions that are contributing to their distress. By creating a genuinely psychologically safe space, they successfully transition the team from a state of paralyzed powerlessness right back to proactive, actionable clinical advocacy. Another incredibly successful evidence-based intervention is the Schwartz Center rounds. These are a real game changer. Unlike standard morbidity and mortality rounds that obsess over diagnostic accuracy and procedural errors, Schwartz rounds focus entirely on the human emotional experience of caregiving. They offer a profound dose effect, meaning the more frequently a clinician attends, the greater their protective psychological benefit. By actively flattening those rigid traditional medical hierarchies and validating the shared emotional burden, these rounds effectively neutralize professional isolation. In fact, they can reduce measurable psychological distress by up to 50%. Section 4. Therapies for moral injury. Let's look at some trauma-informed approaches. Because moral injury is such a deep identity-altering trauma, standard PTSD exposure therapies often fail. They tend to focus on fear habituation. But here's the catch. Moral injury isn't about fear. It's about toxic shame and guilt. That's why we have to look at specialized frameworks like acceptance and commitment therapy for moral injury, or ACTMI. This specific 15-session hybrid model focuses heavily on identifying rigid avoidance behaviors, things like emotional numbing or withdrawing from clinical colleagues, which healthcare workers often use to escape that aversive shame. The goal here is to fundamentally alter the individual's relationship to their moral pain, rather than just trying to treat the negative symptoms. This brings us to the ACT-MI Hexaflex. It utilizes 6 psychological flexibility processes to help the clinician carry their moral pain without letting it completely destroy their professional identity. These include the acceptance of painful emotions, contact with the present moment, self as context to rebuild a shattered identity, reconnection with values, committed action, and cognitive diffusion. Let's break down cognitive diffusion for a second because it's fascinating. It teaches a clinician to distance themselves from a self-condemning thought like, I am a monster for failing that patient. Instead, they reframe it as an observation. I am noticing my mind telling me I am a monster. It sounds simple, but this process literally strips the thought of its behavioral control over the person. We also see the clinical adaptation of something called adaptive disclosure. This was originally developed to treat combat veterans, but it's an incredible tool here. It's an emotion-focused therapy where the healthcare worker engages in a guided, imaginal, empty chair dialogue. Essentially, they converse out loud with a compassionate moral authority, maybe a highly respected mentor, or even a future healed version of themselves. Through this deliberate vocalization, the clinician is guided to accurately separate systemic institutional failures from their own personal ones. It's a complex process of moral repair that integrates the trauma into their broader life narrative, helping them achieve self-forgiveness without being permanently condemned by the event. Now, for a really vital preventative measure, let's talk about stress first aid, or SFA. Using a color-coded stress continuum, this peer support triage model empowers clinical teams to spot the signs of stress injury in their own colleagues early on. It relies on 7 core actions: checking, coordinating, covering, calming, connecting, and building competence and confidence. SFA fosters a rigorous culture of mutual surveillance. The whole point is to stop acute occupational stress in its tracks before it calcifies into chronic psychological injury that requires formal psychiatric intervention. Moving on to Section 5, Pediatric Palliative Care Dynamics. This is a truly unique and highly challenging moral landscape. A massive driver of moral distress in this specific subspecialty is what's called triadic decision-making. Unlike adult medicine, where autonomy rests strictly with the patient, here you're dealing with a constant, incredibly complex negotiation. You have to balance the medical team's objective assessment, the parents' deeply held cultural beliefs and wishes, and the evolving autonomy of the child.
Moral distress spikes acutely when clinicians feel institutionally or legally forced to provide aggressive, life-prolonging treatments that they genuinely perceive as non-beneficial, or worse, actively contributing to a vulnerable child's suffering. Having to respect devastated parents while simultaneously trying to uphold the duty to do no harm, it constantly forces clinicians into deeply compromised ethical positions.
This brings us to a really fascinating paradox in pediatric palliative care. There is this intense duality of deriving deep existential fulfillment from facilitating a good death while simultaneously absorbing immense emotional trauma. Think about it. Prolonged, continuous exposure to the suffering and mortality of children absolutely guarantees profound emotional exhaustion. We widely recognize this as compassion fatigue. And yet, despite that, these professionals consistently report exceptionally high levels of compassion satisfaction. So any scholarly interventions in this space have to do much more than just mitigate trauma. They must actively acknowledge and amplify this profound sense of existential meaning.
Finally, Section 6. Building resilient, ethical climates and focusing on systemic responsibility. We need to talk about a massive warning sign straight from the empirical literature. When healthcare systems prioritize financial metrics over actual clinical care, and they rely exclusively on individualized resilience training without ever addressing the root systemic causes, they risk weaponizing the very concept of resilience. Let me be clear, claiming moral distress is merely a failure of personal coping in a chronically understaffed or toxic environment is deeply, deeply harmful. It inaccurately frames what is a completely healthy, rational response to a compromised ethical environment as some sort of personal psychiatric failure. So, how do we achieve sustainable change? Healthcare organizations have to step up and foster robust, resilient, ethical climates. This means establishing comprehensive ethical infrastructures. It means explicitly empowering clinical ethicists across all hospital units, implementing highly transparent policies for how scarce resources are allocated, and crucially, ensuring that executive leadership actually validates and acts upon the moral concerns of frontline staff. You see, maximum mitigation of moral suffering is only achieved when morally resilient individuals are actually allowed to practice within ethically aligned, highly supportive institutions.
I'll leave you with this final thought to consider regarding the macro-level implications of organizational ethics on the very survival of our healthcare system. We have the data. We possess the psychometric tools to measure the suffering, and we have developed the trauma-informed therapies for repair. But unless leadership steps up to systematically dismantle the institutional barriers that create this suffering in the first place, the mass exodus of our most empathetic, highly skilled clinicians is only going to accelerate. So, what steps will your institution take tomorrow? Thank you so much for joining me for this explainer. Keep questioning, keep learning, and I'll see you next time.